I'm really excited for this session we're about to have. Is there a reason why it's not? Oh, technical issues? Oh, yeah. But I'm still really excited anyway, because this session is really fun. And if I could bottle it up or record it, if anyone's got a camera, I would want to replay it for my patients, because this is the kind of stuff that happens almost every day in the clinic when we meet someone with a new diagnosis or a new suspicion of ITP or someone with a low platelet count, because these are the sorts of questions that race through a lot of people's minds. So, fact versus fiction, myth-busting ITP. Now, this is an interactive session, so if you've all got your phones ready, the first one's is everyone ready? Anyone need more time? All good? Okay. First question. Rituximab is a chemotherapy drug. And the question really is it fact or is it fiction? And the answer is it's fiction. So rituximab is actually a commonly used medication in ITP. It is part of chemotherapy that we often use for cancer patients with a particular type of disease, but it's an antibody treatment. It's an antibody that's made in a laboratory. It has side effects, but it's not chemo in the sense that it's going to make you lose your hair and make you really sick that way, but there's always side effects with every medication. Fun fact, though, we'll probably be seeing more of rituximab earlier in ITP. New guidelines are coming from the Americans, so the ASH guidelines on treating ITP. There was heated debate late last year, but it seems very likely that when people are newly diagnosed with ITP, this is 2026 going forwards, some of your doctors or some doctors will be getting people to start rituximab as they're being diagnosed. So up front. How many of you guys have had rituximab? So maybe only half a dozen. And how many of you have not had rituximab but have ITP? So that's actually a lot more. I'm surprised by that. So in future years at this sort of conference, it might be absolutely tipped the other way. So the next question, if your platelet count is low, you will have bruises and bleeding. Fact or fiction? We've had a few tips on this already, if any of you were paying attention. So it's fiction. How'd you guys go? Mostly pretty well? I mean, it's true, like the thing that we fear a lot of the time when you have no platelets or very poor quality platelets is bleeding. But we've heard from others, and it might be part of your own experiences as well, that the platelet count itself doesn't really predict too well for bleeding. And there are people who have sometimes single-digit platelets and not a skerrick of bleeding whatsoever. But bleeding isn't really the only problem with ITP. And so you've probably also heard that things like fatigue and energy levels, poor sleep, anxiety, these are all symptoms that are commonly quoted and described by people with ITP. It's not just bleeding, but bleeding is certainly one of the things we really worry about. Okay. If you fail one TPO agonist, so a TPO RA are drugs like eltrombopag, otherwise known as Revelade, romiplostim Nplate, or avatrombopag Doptelet. If you fail one of those drugs, would you have a different experience, or could you have a different experience with a different one? Or is it just like a class effect? Are they all the same? Yeah, that's pretty good. So everyone's been paying attention. So absolutely, there's good data actually now to support the fact that there are a lot of people who get a response when they switch TPO agonists or thrombopoietin receptor agonists, even if the last one wasn't working, or if it was not working because they couldn't take a high enough dose because of side effects. So it's absolutely worth switching. And for about 2 years now, or 2.5 years, it's been absolutely possible to do on the PBS. Before that, it was really hard switching between the TPO agonists. Basically, your doctor would have had to have lied for you, but these days it's a lot easier, so it's definitely something worth exploiting. Okay. You can't fly when your platelet count is under 30. True or false? Yeah, that's pretty good. Okay, so basically there's no real platelet count that is a threshold for safety when you're flying. Absolutely, people with single-digit platelets can fly quite safely. Sometimes the problem in my mind is the duration of time you're up in the air if there is something that went wrong. And if you are someone who's had a lot of bleeding, doesn't matter what the actual platelet count is, if you're unstable, that's a risk, that's a problem. The actual number itself shouldn't deter you from being confident enough to travel, to go overseas, to see family, or to go to have a holiday. Definitely having a stable count, having a strategy, having a track record or a history of being okay with the platelet count where it is, all of those things help. Maybe having a bottle of tranexamic acid would also help. And not doing any kickboxing on the plane would also help. Okay, we talked about this already, so again, were you paying attention? Fatigue isn't one of the symptoms of ITP. Yeah, that's pretty good, absolutely. So how many of you guys here actually experience fatigue and have ITP? Yeah, so that's pretty much everyone here. And look, I mean, fatigue's a common symptom that all of us experience with or without ITP, and probably even before you had ITP. But it's definitely a lot more commonly reported in patients with ITP. And it's even seen as the number one most dominant side effect of ITP on patient surveys. And there are lots of different theories for why it might happen. We probably don't have the time today to sort of explore why that is, other than to know that you're not alone. You're not going crazy. It's probably part of your disease. It won't necessarily get better just because your platelet count's a little bit higher. But it is well recognized as being part of your disease. You can't have children if you have ITP. True or false? That's great. That's great. Not a lot of controversial questions coming up, but I think it's still really important to appreciate the fact that although you can have children with ITP, a lot of women who go through pregnancy with a prior history of ITP will experience some increasing difficulty. There are some patients I have who only have ITP when they're pregnant. And there are other patients, and those patients, their ITP gets a lot better as soon as the babies come out. So that does happen, but that does not mean that those people shouldn't consider conceiving or having children. And just because you have ITP before pregnancy doesn't mean your ITP is going to get worse or be too dangerous just because you want to start a family. These are still all very real possibilities. It's just going to take a bit of extra care, a bit of extra testing, a bit of extra shared care management decision making, and hopefully the assistance of great practice nurses like Rebecca. This is a topic that's close to some of us. Clinical trials are only for people who have run out of options. Do you have to be scraping around the bottom of the barrel? And that's great. I mean, in reality, it depends very much on the study or the trial that's available in the place near you. A lot of trials with some drugs are only for people who've run out of options, but there are also a lot of other studies or other trials that are recruiting people just as they're being diagnosed or just as they're needing their second line of treatment. So it depends very much on the study and on the trial. But it is true that historically, the majority of trials were for people who'd already failed steroids, IVIG, thrombopoietin receptor agonists, those sort of things, before you could get into the study. But it's not always that case. And so it really depends on who your doctor is and where you are. People with ITP can't donate blood. True or false? Yeah, that's a good one, because that sort of divides the room a little bit better. It's a fact. If you have an autoimmune disease like ITP, it is important not to donate blood. You'll get screened by Lifeblood and it'll come out and they will most likely identify that you shouldn't. But in actual fact, there were very interesting trials that scientists and doctors did many years ago where they took blood from people with ITP and injected it into healthy volunteers and other doctors, and those people got ITP as well. Yeah, transiently, like it only lasted for a few weeks, but long enough for the platelet counts to crash. So it can be dangerous, donating blood products that way. But that doesn't mean you can't be active in encouraging your family or your friends to donate blood, because plasma and blood are really important and in short supply at times. And particularly you've heard of medications like IVIG or intravenous immunoglobulins. They come from plasma donations that people give, that healthy volunteers give. And just because you yourself might have ITP doesn't mean you can't get active in encouraging other people around you to donate and help out in the cause. ITP is a blood clotting issue, like you can't make a blood clot. So that means you can't get thrombosis. True or false? Yeah, well done. Because again, it was just one of those things that came out in the wash earlier on with some of our previous speakers. Patients with ITP absolutely can get blood clots. It does happen, but it seems to happen a lot more in people who've lost their spleen or had their spleen taken out. So splenectomized patients get a lot more blood clots. And then if you've had your spleen taken out and then you're asked to be on a thrombopoietin receptor agonist, that seems to increase that risk a lot more. But if you have your spleen intact and you're not on a thrombopoietin receptor agonist, there's still a feeling that there's a tiny increased relative risk of having a blood clot, even though you've got ITP. But it's very hard to measure, and it comes back to the whole sort of question of how you interpret risk. It's slightly increased, but it's very hard to do anything about it. Here's a question. Does ITP run in families? True or false? Yeah, I like this question because I wrote this one. It's really important to be careful. There are probably, in fact, there definitely are some people here who've got family who might have lupus or rheumatoid arthritis or thyroid disease or celiac disease and ITP. So there does seem to be a family risk of genetic predisposition or genetic vulnerability to getting immune diseases that we see all the time. There aren't too many families with ITP members. They do exist, but not too many. That's more the exception. And in actual fact, if I meet someone who tells me their mum's got ITP, their grandma's got ITP, and my brother's got ITP, sometimes I'm actually suspecting they have something quite different called an inherited thrombocytopenia, or that's one of those genetic diseases or genetic situations where you're born not able to make platelets at the right number. So that's a bit different to ITP. But historically, people used to get treated like ITP because we didn't have good tests for it. Now we have pretty good genetic tests for it. So yeah, if you do come from a family where there's been a lot of diagnoses of ITP, it's worth having another think about that diagnosis. And how about this one? ITP gets worse after vaccinations. Again, I like this question because I wrote it. Yeah, and again, that'd be about right, because some of you will have had experience with this as well, where you've had a vaccination or you've had a viral illness, and maybe your platelets fell a bit. It's my feeling that there will absolutely be some of you whose platelet counts will fall after you've had a vaccination. But those people who have that reaction to vaccination are just as likely to have had a fall in their platelets after a viral illness. And in fact, it probably reflects that your ITP is a little unstable already. It's a little vulnerable to fluctuations, whatever it is. Emotional upset, viral illness, a new medication, travel, someone died in the family, whatever it was. It's something that's rocked the boat. And vaccinations can do that. But they don't necessarily cause ITP in the first place. And they don't actually make the disease worse. They don't change the disease, just like a viral illness doesn't really change the disease. It just might trigger a little bit of up and down, but that's not the same as making it worse. And you stand to gain a lot more from being protected from an infection, particularly if you're on immunosuppression or you've been on immunosuppression, like rituximab or like steroids, than to run the risk of not having any protection from an infection. And you'll probably will have a flare of your ITP when you end up with pneumonia anyway. So yeah, that's it. I think that's the end of all the fact and fiction. Thank you very much.